That brings in next participant, Dr. Madhura TK from Belgavi. You introduce yourself in one line and then do your presentation. Your time starts now. You've got 8 minutes to present.
Good morning, everyone. My name is Dr. Madhura TK. I'm working as assistant professor in biochemistry from JNMC, Jawaharlal Nehru Medical College, Belgavi. So this case I'm presenting where this case I had seen and I'm in continuous follow-up. I had worked as a medical officer for 1 year in DRDO, Khadakwasla. So this is a case when I had seen it. This is a 36-year-old Ayurvedic doctor weighing 94 kg, presenting to OPD with skin changes. That is acanthosis nigricans and skin tags, which is affecting the nape of the neck and both axilla. With this, he has a dragging pain in both upper limbs. He is a known case of cervical spondylosis. On the X-ray, it shows the reduced space between C5, C6 and C6, C7. Symptoms, he says this symptom of dragging pain was relieved on taking intramuscular injection of Neurobion 4. So while taking history, when inquired about his family history, he said that the paternal grandparents, both of them were diabetic and father is diabetic. So this is all the 3 generations seems to be having a risk factor. His present medications, since he has a signs of insulin resistance, he was prescribed to take tablet metformin by a physician 500 milligram twice daily. He also complains of bloating and retrosternal burns accounting to metformin. So whenever he skips this metformin, he is usually relieved of this symptom. So to combat this symptom, he is taking an antacid, pantoprazole 40 OD. His anthropometric readings are as follows: weight 94 kg, height 165 centimeter, BMI would be 34.5 kg per meter square, which starts in grade 1 obesity. Waist circumference 115, hip circumference 95 centimeter, waist to hip ratio is 1.21, which is very high. Fasting and PPBS is normal. HbA1c is 5.6%, which is normal, and serum B12 concentration when measured is 193 nanogram per ml. So the question for me is, patient is aware of the B12 deficiency with metformin therapy, and what is the suggested dose and frequency of B12 supplementation? So to give a background of B12, we know this is a water-soluble vitamin and the source being usually the animal foods. In the plant foods or the vegetarian sources, we can say curd and milk products. Curd is a better source because of the presence of lactobacillus. So what is the required dietary allowance of B12 for us? It is very low, very low quantity, 1 to 3 microgram per se. So the speciality of this vitamin is this vitamin can be stored. The storage organ is liver. How much can it be stored? For around 4 to 5 milligram, and which would give a backup for 5 to 6 years. Suppose the patient is presenting with the symptoms, that means he has already exhausted with his storage. And the one more fact of vitamin B12 and his presentations with for the dragging pain is that this vitamin B12 acts as a coenzyme where it converts the succinyl-CoA to malonyl-CoA with the help of a enzyme methyl-malonyl-CoA mutase. So when there is deficiency, this conversion doesn't occur, and this malonyl-CoA will start inhibiting the formation of myelin sheath by inhibiting the synthesis of fatty acid. So thus we can account for the vitamin B12 deficiency with this. So how much should be supplemented? Is it fine that whenever he gets the pain, should he take the injection, or can we supplement him orally with a particular dose? Because assessing B12 very frequently would be, it would be a burden on the patient economically, because that test itself would cost more than 2,500. So within that amount, I think he can account for the whole of the therapy. So what is the suggested dose and frequency of B12? Sir, my suggestion would be, is it fine if we give him 500 microgram every day once daily, or 1500 microgram every day once daily? Should we give him a dose of, I would prefer him, we can give him 1500 microgram daily for 6 months. Orals.
So anyways, so B12 you said requirement is very low. First thing. Second thing is we have a number of studies which have looked at what should be the dosage of B12 for patients who have deficiency of B12. So deficiency is common because of two reasons in diabetic patients. One, pure vegetarianism, which is one of the major causes of deficiency that we see in Indian patients. Second is the use of metformin. Metformin, about 30% of the patients get into vitamin D B12 deficiency. There are a number of studies which have explored anything between 10 microgram to 1000 microgram as replenishment dose on daily basis. Now, the results are very variable. We do not know what is the exact dose. The correct answer is, to best of my knowledge, we do not know the correct dose. But the usual supplementation that is recommended is anything between 500 to 1000 micrograms on daily basis
For
for B12 deficiency. Now,
6 months, 3 months?
no, it has to be ongoing if patient is on metformin, or for that matter, if somebody is vegetarian, has already gone into deficiency, that means you need to supplement it. Second thing is, what happens is most of these patients are seeing multiple physicians. And now every B complex preparation is having some B12. And you will suddenly realize that after 1 year you do B12 and you will find the levels at 2000 plus.
Okay.
So you should make sure that if you are supplementing B12, everybody else is not, or patient is not taking multiple preparations of B12. Though this vitamin fortunately does not have any toxicity and gets washed out because of the excretion through urine.
Yeah.
So that's not a big challenge. Second thing is there are studies which have compared oral and parenteral route of B12 administration. There is no difference. Third, B12 deficiency is never an emergency.
Yeah.
So there is no, concept behind giving a parenteral B12. Unless you are suspecting total, malabsorption happening because of some reason, or pernicious anemia, or even PPIs can interfere with B12 absorption. Prolonged use. So these are the things you have to keep in mind.
Did you check the levels in this patient?
Yes.
After giving injections?
No, sir. That patient used to take because
Before therapy?
he's 193.
193.
193 is again borderline. It's not.
Low
Less
side.
than 200 is usually
200,
considered as
250,
deficient.
225.
11 is the cutoff.
And second was that, what were the classical symptoms which you thought were because of B12 in this patient? Symptoms are very, very vague. Well, you checked it, levels were low and you supplemented, that is fine. Patient
Yes,
was
sir.
on metformin, but there
With
was
the
nothing.
background history, that one is he's a pure vegetarian by diet. Second, he is on metformin therapy, and his symptom. So,
No, but symptoms you said are very,
Homeopathy can be,
yeah, that
can
really will.
be placebo.
that is what I'm
That
saying.
placebo effect
You
might be
don't
there. Also.
expect the injection of neurobion.
Did you look for neuropathy signs in this patient? Did you document that patient has at least bedside signs of neuropathy? Because vague symptom of pain, that too in upper limbs, is very, very unclassically seen in B12.
So
Very, very unclassical.
what you saw in terms of relief of pain in response to injection is a placebo effect.
Okay.
Because one shot of neurobion cannot reverse or cannot cause remyelination of the nerves, which is not impaired in one shot. It will not happen overnight. So it's more like a placebo effect. And symptoms of neuropathy are largely because of the diabetic process, but this may be a confounding factor.
American Diabetic Association says that in the past they were saying you have to screen the patients on metformin therapy every 4 years. Now they made every 1 year. Annually to screen, and you check the B12 only once a year, not frequently. It is not like blood sugar, keep on checking. But there's also in that paper they presented at the IDEC, they say parenteral therapy works better because the intravenously absorption of metformin is far superior. The competition for the calcium at the terminal ileum, the metformin is faster than the B12.
So how frequently you want to give an injection?
You can start once a week, go on once in 2 weeks and once a month.
No, that's fine. I agree with you. There are studies which showed a little better B12 levels with injectable, but there are studies which did not show any difference. Now my question is, what is the urgency of replenishing B12?
See, the treatment is based on two aspects. One is the improvement of B12 level, which is necessary for the methyl donation for the nuclei. You get the polylobed WBCs in these patients because of the B12 deficiency.
It is very well absorbed otherwise. And it's a
So the
vitamin which is very well absorbed unless you have reasons for.
Yeah, so the anemia part and the metabolic part requires the good levels of more than 345 or something. But the symptom relief of peripheral neuropathy may not occur at all. Because that is difficult to treat, because these patients with neuropathy are very resistant to treat. And they are classically nocturnal. If you get patients with nocturnal pain, they get up in the night, that's the classical feature of peripheral neuropathy because of B12 deficiency or any peripheral neuropathy in diabetic patient.
Thank you.
Thank you, sir.